So in microbiology, the most important things that you have to understand is about the various organisms and the infection they cause. Bacteria, the basics of bacteriology and the classification, the basic of virology and its classification, and some common infections, including the genital tract infections and sexually transmitted infections, viral infections in pregnancy. Torch, GBS is given special importance. We have a separate GTG itself on GBS, so it's an important thing. And a hot topic on antimicrobials and the resistance that is seen commonly. Once we discuss these topics, we'll look into some common SBAs that can be asked in this topic. So coming to the first topic of importance is bacteriology, the basics of classification of bacteria. The bacteria can be classified based on gram staining. The gram staining is going to distinguish the bacteria by the presence of cell wall. Now, whenever you have a gram positive bacteria, that means it's going to stain purple or blue. This is because of the thick peptidoglycan cell wall. When we talk about the gram-negative bacteria, in addition to this, it also has an outer liposaccharide membrane which helps it stain pink in color. So pink is gram-negative and purple or blue is gram-positive. That's the first thing. Second thing you need to understand the common organisms here. Gram-positive can either be classified into cocci and bacilli. Same applies to gram-negative also. So the cocci are nothing but round-shaped bacteria and bacilli is nothing but rod-shaped bacteria. Now coming to cocci, the most common ones are Staphylococcus, which are seen in clusters. The most common example is Staph aureus. Now coming to streptococci. Streptococci is an important one. This appear in chains. The most common examples here is your group A streptococcus or streptococcus pyogenes, which is commonly seen in necrotizing fasciitis, post-op wound infections. And we have our group B streptococcus, which is streptococcus agalactiae. And this is the one that we test in the vagina for all pregnant women in later part of pregnancy. So this is the importance that you have to remember here. Coming to other examples, gram-positive bacilli, the common ones are Listeria, Clostridium bacillus, and Corynebacterium. Coming to gram-negative cocci, we have Neisseria. Again, one of the most common organisms seen in sexually transmitted infection. This is an example of a gram-negative cocci. So what are the key points that you need to remember here and what are the exam SPAs? In your exam, you might be tested on asking a particular organism and they can ask you what type of bacteria it is, whether it is gram-positive or negative. And another thing that is commonly seen in exam is based on the toxin development that these bacteria can have. We have two different types of toxin. One is your endotoxin and one is your exotoxin. Now, what is an endotoxin? Endotoxin are most commonly seen with your gram-negative bacteria. It is seen from the outer membrane. And exotoxin is seen with your gram-positive bacteria. Your endotoxins are heat stable and your exotoxins are heat labile. Example of your endotoxin is going to be say one seen in septic shock. Whereas if you look at your exotoxin, your tetanus is a common example of your exotoxin. So again, toxins can be one of the SBAs that you see in your exam. So, what are the most important things that we just saw? Your gram-negative bacilli, again E. coli, Klebsiella, Proteus, Gardnerella, again, which is seen in a vaginal discharge. All these come under gram-negative bacilli. Now, looking at the bacterial structures. Capsule has an antiphagocytic role. Flagella is used for motility of the bacteria. The pili or the fimbria help in adhesions of these bacteria. Your endotoxin, as I mentioned earlier, this is for your gram-negative from the outer membrane and this is your heat stable. Whereas your exotoxin is secreted from the proteins and this is most commonly seen with your gram-positive bacteria and they are heat labile. Very, very important point for your exam. Now, what are atypical bacteria? Atypical are one which do not gram stain and which do not have a cell wall. Example for this is going to be your mycoplasma, your chlamydia. Chlamydia are again commonly seen with STI. They are obligate intracellular organism. Another organism which comes under this atypical category is your Rickettsia. Now, whenever this organism require oxygen, we take it as aerobes. And without oxygen are your anaerobes. We have bacteroids and Clostridium come under this. And you also have some organisms which are facultative aerobes. That is, if available, they use the oxygen. If unavailable, they can survive without the oxygen also. Now coming to the culture media, we know there is multiple organisms which requires multiple culture, but the most common one that I will let you all know is about the chocolate agar in which your Neisseria and your Haemophilus is going to grow. And also you have your blood agar. So in blood agar, when the organisms grow, you look for hemolysis. So these are some common things that you have to remember here. Apart from this, an exam tip will be to have a look at the images, because these images can also come in your exam and they can ask you what is the organism that you're seeing there. So another tip for your exam. So, the important recalls that has come in the basics of bacteriology and the classification are: one, it is about the gram positivity and the gram negativity. Positivity is purple because of the thick peptidoglycan layer. Negative is because of the LPS outer membrane, so pink color. Staphylococcus clusters, Streptococcus chain, and your Staph aureus is coagulase positive. Important point for your exam. Your GBS, example of your group B Streptococcus is nothing but Streptococcus agalactiae. And your endotoxin is because of the LPS, which is gram negative and it is heat stable also. Exotoxin is heat labile, it is secreted. Now coming to chlamydia, you need to understand chlamydia is an obligate intracellular organism. The capsule of the bacteria has the antiphagocytic role, and the last point to remember here is about, once again, the last point is about Neisseria, which is a gram-negative cocci, again commonly asked in exams. So always these organisms will be correlated with the clinical infections that we see. So that's another important area which you can focus on while revising. Now, coming to the next topic, which is on genital tract infection and sexually transmitted infections. The most common bacterial STI is your Chlamydia trachomatis. The Chlamydia trachomatis is an obligate intracellular organism. Most of the times it is asymptomatic. Keep this in mind. The woman is not going to have any symptoms. What are the complications? Remember this as a silent killer. So this can cause pelvic inflammatory diseases, tubal infertility, ectopics, and Fitzhugh-Curtis syndrome, wherein you find adhesions in your subdiaphragmatic space. How are you going to diagnose it? Diagnosis is by taking your vulvovaginal swab. You do your NAT test. Treatment is doxycycline. For pregnant women, you use azithromycin. Second most organism that you're going to see here is your gonorrhea, Neisseria gonorrhea, which is a gram-negative diplococci. The difference between chlamydia and gonorrhea is going to have purulent discharge, and also the baby is developing at risk of developing ophthalmia neonatorum, which is again seen in chlamydia also. The diagnosis of this is going to be using NAT. You can do the culture test also. The treatment of choice is going to be IM ceftriaxone. These are the key differences between chlamydia and gonorrhea. Again, one common area where it can be as a trap for the exam going candidates. Know the difference between chlamydia and gonorrhea. And coming to syphilis. Now, syphilis is caused by the organism Treponema pallidum, which is a spirochete. The primary syphilis, it causes painless chancre. Secondary, you will have a rash, especially in the palms and soles, and you have your condylomata lata. Coming to tertiary syphilis. Tertiary syphilis is all about development of gummas, your neurosyphilis, your cardiovascular complications, all this come here. Congenital infection is quite serious with syphilis. How are you going to diagnose this? The diagnosis is by using dark field microscopy. You can use the serology. In serology, you have VDRL, RPR, and TPHC. Now coming to the treatment of choice. The drug of choice is going to be benzathine penicillin. Now, what are the key points you need to keep in mind whenever you're talking about your vaginal infections? So one is for chlamydia, we saw the organism Chlamydia trachomatis. The drug of choice is doxycycline. Gonorrhea is by Neisseria gonorrhea. Purulent discharge is the classical feature here, and the treatment of choice is going to be ceftriaxone IM. Syphilis is Treponema pallidum. You have your painless chancre. So syphilis, painless. Always keep that in mind. And your drug of choice is going to be benzathine penicillin. Apart from this, what are the other non-STI we talk about? One is bacterial vaginosis and one is the candida infection. Trichomonas again comes into STI category. And bacterial vaginosis is caused by the organism Gardnerella vaginalis, and the classical feature here is going to be the clue cells. And you do your whiff test and your pH is less than 4.5. And this discharge is going to be a thin grayish discharge. The drug of choice is going to be metronidazole. Next, coming to trichomonas. Trichomonas is caused by the organism Trichomonas vaginalis. This is going to give you a frothy vaginal discharge, and the typical appearance of the cervix is going to be called as a strawberry cervix. The drug of choice here is once again going to be metronidazole. Finally, coming to the yeast infection, the fungal infection of Candida, most common organism is Candida albicans. The classical discharge is going to be a thick, curdy vaginal discharge or cottage cheese appearance, and itching is going to be quite severe here. The drug of choice is going to be clotrimazole or fluconazole. So, genital tract infections and STI, especially the vaginal discharges, is a very, very common topic that you can see in your exam. You need to know the name of the infection, the organism, the key classical feature which can help you diagnose it, and the drug of choice. So, this is commonly asked in exam. So, bacterial vaginosis, as we just saw, is caused by Gardnerella, which is an anaerobe. This is not an STI. Now, what happens in bacterial vaginosis is there is loss of the protective bacteria, which is your lactobacillus. So, there's a thin gray discharge, and you have clue cells, and the whiff test is your test of choice for this. The treatment is metronidazole. Now coming to Trichomonas vaginalis, which is a protozoa, commonly asked as a picture also. You need to know the picture of Trichomonas. It is a flagellated motile organism that you see under microscopy. The cervix is going to be strawberry cervix, and the discharge is going to be a frothy greenish yellow discharge. Next, coming to Candida. Candida is nothing but a fungal infection. You have a thick white cottage cheese appearance. The drug of choice is going to be clotrimazole or fluconazole. Now, what are the other infections that you have to keep in mind? Genital herpes. Genital herpes, your HSV2 is more common than HSV1, and this causes painful recurrent ulcers. Next, you have genital warts. Genital warts is nothing but a condyloma acuminata, which is seen in HPV1, HPV6 and HPV11, which is your papilloma virus. Now coming to pelvic inflammatory disease. Pelvic inflammatory disease is generally polymicrobial, that is multiple organisms will be seen. Now, one syndrome that is seen in PID is your Fitzhugh-Curtis syndrome, which is nothing but the perihepatitis, and this is classically seen with chlamydia infection. So what are the key topics that we saw here? The more commonest bacterial STI is chlamydia. It is an obligate intracellular organism. And how are you going to diagnose? It is with the NAT test. Gonorrhea is a gram-negative diplococci. The drug of choice is going to be ceftriaxone. Syphilis is with Treponema pallidum. The drug of choice is going to be penicillin. Bacterial vaginosis, you look at the clue cells, you do the whiff test, and your pH is more than 4.5. And trichomonas is frothy discharge with strawberry cervix. Your bacterial vaginosis and your trichomonas, for both of them, the drug of choice is going to be metronidazole. And for candida infection, it is going to be cottage cheese, and it is not considered as an STI. Now, Fitzhugh-Curtis syndrome, we saw it is with chlamydia, and there will be perihepatic adhesions. Human papillomavirus 6 and 11 for the warts, 16 and 18 is for the cancer. So these are some key hot recall topics in this genital tract infections. Now coming to next important topic, which is viral infections in pregnancy. Now coming to the key viral infections, the first one is going to be on cytomegalovirus, which is the commonest congenital infection that we see. Now, what can this do to the baby? This can cause sensory neural hearing loss. It can cause periventricular calcification, and it can cause IUGR in the babies. There is no routine screening for CMV, and there is no vaccine also available for CMV. So CMV can also come as an image-based question wherein they can give the classical features in the baby, and they can ask you what is the organism that is involved here. Second one is your rubella. Rubella is nothing but it belongs to your toga virus category. Congenital rubella is important. It has a triad of cataract, PDA, deafness, and microcephaly. Highest risk is when the woman is having the infection at less than 12 weeks. The vaccine for rubella is your MMR vaccine, but since it's a live attenuated vaccine, avoid it in pregnancy. Next, coming to parvovirus. Parvovirus B19, it is also called as slapped cheek syndrome. It is the most common cause of fetal anemia in UK, very, very commonly asked SPA. Because of this fetal anemia, it can lead to hydrops fetalis and intrauterine fetal death. Next, it can also cause aplastic crisis, and it can affect the erythroid precursors. Another common infection of virus that we see in pregnancy is your varicella, nothing but chickenpox. Now, whenever a woman is going to get chickenpox at less than 20 weeks of pregnancy, this can lead to congenital varicella syndrome in the baby. And this congenital varicella syndrome can typically have limb hypoplasia and scarring. A perinatal, like 5 days before and 2 days after birth, this is associated with severe neonatal infection. So whenever a woman has got chickenpox, try to avoid delivery at the earliest. Give some time for the antibody production. Apart from this, a very, very important area, a virus that you have to know is your hepatitis B serology. Now, hepatitis B serology, you need to know whenever a woman has got HBsAg positive, that means she is currently infected. Whenever a woman has anti-HBc IgM, it is an acute episode. Anti-HBc IgG means it's a past exposure. Whenever a woman has got HBe antigen positive, that means she is highly, highly infected. And if the woman has anti-HBs antibody, that means she has become immune. So what are the key factors or the key questions that you can expect here? They can give you the serology and they can ask you the diagnosis or the interpretation of the serology. Now, when a woman is vaccinated, we see that she has got anti-HBs. Only that will be present. When the woman has got past infection, that means she's immune, she's going to have anti-HBs and anti-HBc also. Chronic will be having HBs, but it will be like the time duration will be more than 6 months. So why is hepatitis given a lot of importance? Hepatitis is again one of the vertical transmission is quite common here. We talk a lot about HBs vaccination also. So hepatitis B is one common condition in which you can either have an image and they can tell you to interpret, or they can give you the serology and they can tell you to interpret on what that serology means. Now HIV. Now, HIV is your human immunodeficiency virus. The vertical transmission gets reduced to less than 1% whenever the woman is started on antiretroviral therapy. The mode of delivery is diagnosed with the viral load. The vaginal delivery is allowed whenever the viral load is less than 50 copies per ml. If the viral load is more, then we always offer or prefer cesarean section. If the woman is in high income setting, avoid direct breastfeeding also. Now coming to hepatitis B, we just saw hepatitis B. We saw the serology of how it works. Just going through it once again. HBsAg is current infection. HBeAg is high infectivity. This is a key difference, a key point that is seen in SBAs. Coming to anti-HBc IgM is acute. Anti-HBs is always suggestive of immune. That means recovered or vaccinated. Vertical transmission is very high whenever the woman is HBe positive. That means quite infectious. We have a neonate of an HBsAg positive mother. Then what do? You give both vaccine as well as immunoglobulin at birth. Hepatitis C, there is no vaccine and it also has a lower vertical transmission. Coming to herpes simplex virus, the primary genital herpes simplex virus in third trimester, if the woman has got, then go in for cesarean section. This needs to be offered to the woman. Neonatal herpes is associated with high mortality, so that has to be kept in mind. Now, viral infections, what are the key things that we just discussed? The commonest congenital infection is with cytomegalovirus. With rubella, we saw there's a triad of cataract, PDA, and deafness. Parvovirus B19 is associated with fetal anemia and hydrops. Varicella, chickenpox, less than 20 weeks, is associated with congenital varicella syndrome. HIV, the vertical transmission goes less than 1% if the woman is started on ART. Hepatitis B, you give neonatal vaccine and HBs and immunoglobulin at birth. This is very important, very commonly asked. SBA, what do you do with a neonate of a mother with HBsAg positive? Now, HBsAg is infection, anti-HBs is immunity. If only anti-HBs is present and there's no antigen, then you have to remember this is a case of vaccination alone. HBsAg, anti-HBsAg and anti-HBc, if both are present, then it is a past infection. Primary HSV, herpes simplex, in the third trimester, remember, avoid normal vaginal delivery, offer her a cesarean section. Zika virus is associated with microcephaly. And MMR and varicella are live attenuated vaccine. Avoid them in pregnancy. GBS, group B streptococcus, we have, if the woman is diagnosed with GBS positivity, then you have to provide her intrapartum penicillin prophylaxis. So these are some key topics in virology that you have to keep in mind. So coming to other perinatal infections, especially your torch, GBS, etc. Now what do you mean by torch? Torch stands for Toxoplasma gondii. Now where does it come from? The T, it comes from cat feces and undercooked meat. So these are some key factors you look in your scenario. If they say the woman has got some pet organisms, she has taken food outside, then you have to remember it is torch for Toxoplasma. The baby can have hydrocephalus, chorioretinitis, and intracranial calcifications. O stands for others like syphilis, varicella zoster, parvovirus, HIV, and Zika. R is for rubella, and C is for CMV, and H is for herpes simplex. So this is what TOT stands for. Okay. And next, coming to toxoplasmosis per se. Now, toxoplasmosis, the treatment of choice is going to be spiramycin. It reduces transmission. And what are the other key factors that you have to tell the woman? Tell her to avoid cat litters and raw meat in pregnancy. Listeria monocytogenes, this is a gram-positive bacilli. And what is this associated with? Unpasteurized dairy. You have to think about Listeria infection. What can this do? This can cause miscarriage, stillbirth, and neonatal sepsis. Drug of choice is going to be ampicillin or amoxicillin. Now coming to GBS. GBS is given a lot of importance. The organism is Streptococcus agalactiae. This is the commonest cause of early neonatal sepsis. Now you understand why this is given a lot of importance because of the sepsis it is associated with. The maternal vagina and the rectum carriage rate is almost 25%. Now, what can this do to the mother? It can cause premature death. It can cause prolonged rupture of membranes, previous GBS, baby GBS bacteria. These are all the risk factors. The drug of choice here is going to be intrapartum. You're going to give IV penicillin. Benzyme penicillin prophylaxis is given only in the intrapartum period, not when you diagnose GBS. And in UK, it is based on the risk factor they do the screening, and there is no universal screening advised for GBS. Now, urinary infections in pregnancy. Most of the urinary infections are asymptomatic bacteria. What are you going to do? You're going to screen and treat. Especially this screening and treatment is going to prevent the woman from going into pyelonephritis. Now, which is the most common organism? E. coli is your most common organism, and this is mainly done to prevent preterm labor that is associated with your urinary tract infection. Coming to chorioamnitis. Chorioamnitis will cause ascending infections, maternal fever, tachycardia, uterine tenderness. Okay, this can lead to preterm labor, neonatal sepsis. The main idea is to deliver and give the women antibiotics. Endometritis can cause postpartum fever, and this is generally polymicrobial in nature. Coming to TORCH, GBS, and other perinatal infections, what are the important recalls that we just saw here? Toxoplasmosis is associated with hydrocephalus, chorioretinitis, and calcification. And toxoplasmosis is generally from cat feces and raw meat. And the treatment of choice is going to be spiramycin. Listeria is seen from unpasteurized dairy, and the treatment of choice is going to be ampicillin and amoxicillin. GBS is the commonest cause of early onset of neonatal sepsis, and the prophylaxis is going to be intrapartum penicillin. GBS carriage, if you see, it is almost 25% of women have this GBS. Asymptomatic bacteria, what are you going to do? You're going to see, screen, and treat them. Now, coming to the next topic, which is on antimicrobial resistance. So coming to the next topic, which is on antimicrobial resistance. Now, antimicrobial resistance as such, if you see, it is a very, very important topic because the antimicrobial resistance is increased right now. It is on an increase globally. So what are the main key points that you have to remember here? This resistance, the cell wall synthesis, that is your beta-lactam producing antibodies, your penicillins and cephalosporins, your glycopeptides, all these are going to act on your beta cell wall synthesis. Now coming to protein synthesis. Now which are the antibiotics that act here? Which these are your aminoglycosides, your gentamicin, and your macrolides like erythromycin, which act on the 50S, and your tetracyclines. Now DNAs. For the DNA, you have your fluoroquinolones, which are acting on your gyrase, and your metronidazole, which are your anaerobes. Folate synthesis. This is affected by trimethoprim and sulfonamides. So these are the various antibiotics, and this is their mechanism of action. Now, what are the pregnancy safe antibiotics? So pregnancy safe antibiotics include penicillins, cephalosporins, erythromycin, and azithromycin. At term, you're supposed to avoid nitrofurantoin because this is associated with neonatal hemolysis. And in the first trimester, ideally you avoid metronidazole. Now, what are the important things you need to keep in mind? Now, for your mechanism of action, your cell wall synthesis, we saw this is getting affected by beta-lactams and your glycopeptides. And for your protein synthesis, you see your aminoglycosides, macrolides, and tetracyclines. And again here for your protein synthesis, you must know your 30S and your 50S. Your 30S is your gentamicin and tetracycline, and your 50S is your macrolides. Your DNA and nucleic acid is getting affected by your fluoroquinolones, which acts on your DNA gyrase, and metronidazole, which is acting on all the anaerobic organisms. You have to remember the pregnancy safety ones. What are the
Ma'am,
contraindications here?
sorry, ma'am.
Yeah,
Ma'am, could you please turn on your camera?
I'm sorry.
Thank you.
Now, coming to your drugs that you need to avoid in pregnancy. The contraindicated ones are tetracycline. It causes teeth and bone staining. Second one is your fluoroquinolone. This causes your cartilage damage. And next is your trimethoprim. Trimethoprim, especially in the first trimester, if used, it increases your risk of neural tube defects. Sulfonamides, near term, it is better to be avoided because this causes kernicterus. And aminoglycoside causes ototoxicity, and that is the reason you use it with caution. Now, what are the mechanisms by which the resistance can come? It can be because of this beta-lactamase enzyme destroying penicillin, or your ESBL, which is nothing but your extended spectrum of beta-lactamase, which can cause. So this generally causes resistance in your gram-negative organisms. Your MRSA. MRSA is very, very commonly seen, and this is because of the alteration in your penicillin binding protein 2. Now coming to efflux pumps. So efflux pumps, that acts as a target site modification, and there is a reduction in the permeability of the drug, and hence resistance is seen here. So most important ones are the drugs that are going to be contraindicated in pregnancy, and why are they contraindicated? This needs to be seen. So contraindicated drugs, tetracycline and doxycycline is going to be teeth and bone, that is yellow staining. Fluoroquinolones, ciprofloxacin causes cartilage damage. Aminoglycosides, ototoxicity, use with caution. And trimethoprim, first trimester, you have to use with because it is a folase antagonist. It has to be very, very careful. It can cause neural tube defects. And sulfonamides, near term, if you use it, is going to be associated with kernicterus. These 5 points are very, very vital ones. You need to remember them for your exam. Now, coming to the resistant mechanisms, we just saw what kind of beta-lactamase enzymes do. They destroy penicillin. Your ESBL is your extended spectrum beta-lactamase. Again, it causes the same. MRSA causes an alteration in the penicillin binding protein. And efflux pumps, again, there's a modification in this efflux pumps. So how can you avoid this, or what can you do for protection? You use your antibiotic stewardship. That means when you follow the antibiotic stewardship, you're going to reduce the resistance and you narrow the spectrum wherever it is possible. So, what are the key recalls that you have to remember here? Your beta lactams is for your cell wall synthesis. Your aminoglycosides is your 30S protein synthesis. Your macrolides is your 50S protein synthesis. Your metronidazole is for anaerobes and DNA. Trimethoprim is your folate antagonist that needs to be kept in mind. Tetracycline is contraindicated because of the staining. These points are repeated again and again because they are key recalls that are seen in your exam. Fluoroquinolines causes potential cartilage toxicity. Trimethoprim avoid in first trimester. Nitrofurantoin avoid at term because this is a cause of hemolysis. And lastly, your MRSA. MRSA alters your binding protein. So now let's look into some common SBAs, the common MCQs that are seen in your exam. Going on to the first one, gram-positive bacteria stain purple. And why do they stain purple? Let us look into the option. It is because of a thin peptidoglycan, a thick peptidoglycan, and outer LPS, no cell wall, or whether it is having an acid-fast coat. Now, the answer for this is going to be a thick peptidoglycan layer, and this is the reason it is going to stain purple. Gram negative have a thin peptidoglycan, but they have a superadded outer LPS membrane which is going to stain them pink in color. The commonest bacteria which is associated with sexually transmitted infection in the UK is it gonorrhea? Is it chlamydia? Is it syphilis? Is it trichomonas? Or is it mycoplasma? The answer is chlamydia, which is the commonest bacterial STI. And what are the other things you need to do with, you need to know about chlamydia? One is it is asymptomatic. Second one is you have to remember it is an obligate intracellular organism. Now, what are the complications that you see with chlamydia? It can cause a pelvic inflammatory disease. It is associated with tubal infertility, with ectopic pregnancies, with Fitzhugh-Curtis syndrome. And Fitzhugh-Curtis is nothing but the perihepatic adhesions that you see, and the diagnosis is going to be by NAT. Now coming to the next recall MCQ, which is talking to you about the clue cells. The MCQ mentions there are clue cells, the vaginal pH is more than 4.5 and the woman has a positive WIP test. Now what does this indicate? Is it seen in candidiasis, trichomoniasis, bacterial vaginosis, gonorrhea or chlamydia? Now, the most common organism that we see here and one of the most common MCQ that is seen, this is with bacterial vaginosis. This criteria that we use for diagnosis of bacterial vaginosis is called as Amsel's criteria. The discharge is a thin gray discharge. The pH is more than 4.5. It has clue cells. It has a positive whiff or amine test, and the treatment of choice is going to be metronidazole. Coming to the next recall. In this, if you see strawberry cervix with frothy green discharge, suggesting of what? Is it bacterial vaginosis? Is it trichomonas? Is it candida? Is it chlamydia or herpes? Bacterial vaginosis, we just saw it is all your amine test, your whiff test, everything is seen with bacterial vaginosis. Strawberry cervix, frothy green discharge, this is suggestive of trichomonas vaginalis. And why is it called as strawberry cervix? Because of the punctate hemorrhages this can produce. You need to understand that for trichomonas, it is a motile organism, so you can expect an image also for this. The commonest congenital infection which causes sensory neural hearing loss. Sensory neural hearing loss, is it because of rubella, toxoplasmosis, cytomegalovirus, parvovirus or herpes? Whenever you think about the commonest congenital infection, always think it is cytomegalovirus. And this can cause sensory neural hearing loss, it can cause periventricular calcification, and it can cause IOGR. Coming to maternal parvovirus B19 infection. Now, what can this cause? Is it associated with cataract and PDA? No. Cataract PDA is seen with rubella, fetal anemia and hydrops. Yes. Parvovirus B19 is associated with fetal anemia. It is the most common cause of fetal anemia in UK. Which is the commonest cause of early onset neonatal sepsis. Early onset neonatal sepsis is a very, very important thing you need to keep in mind because of the high morbidity and mortality. Now let us look into the organism. Is it E. coli? Is it Listeria? Is it group B streptococcus? It is staphylococcus or is it Klebsiella. Now, commonest cause of early onset neonatal sepsis is your group B streptococcus. Now, 25% of the women carry it either in their vagina or in the rectum. The drug of choice is going to be intrapartum IV benzyl penicillin. And the risk factors, if you look at UK, this is done only using risk-based and there is no universal screening for this. Now, which antibiotic is contraindicated because of the dental and bone effects? Is it amoxicillin, erythromycin, tetracycline, cephalexin, or nitrofurantoin? Here, the answer is going to be tetracycline. Co-amoxiclav contains clavulanic acid. Now, why is clavulanic acid added here? Is it to improve the oral absorption? Is it to inhibit the beta lactamase? Is it to broaden the coverage of anaerobes? Is it to reduce the renal excretion? Or is it to prevent allergic reaction? The answer here is going to be it is to inhibit the beta lactamase enzymes. So mainly when you look at antibiotic resistance, you need to think co-amoxiclav has clavulanic acid is to mean for this reason to avoid from resistance. Toxoplasmosis in pregnancy is classically acquired from what? So we were looking at the reasons that can cause toxoplasmosis. Is it because of unpasteurized dairy, cat feces and undercooked meat, mosquito bites, respiratory droplet or sexual contact? And the answer here is going to be from cat feces and undercooked meat. So Toxoplasma gondii is acquired from cat feces, the litter of cat, and from undercooked and raw meat. This can cause hydrocephalus, chorioretinitis and intracranial calcification. The treatment of choice here is going to be spiramycin. Now, the next hour is going to be with immunology. We are going to look into the various topics of immunity, hypersensitivity. Allow me 2 minutes and we shall restart. Stay in the line and please do not leave the room. All right, so the questions that we had right now is on CMV. What are the specific points you need to understand? CMV is cytomegalovirus. It is the commonest neonatal infection that you can see. And most of the women are asymptomatic. And what it can do to the baby, it can cause hydrocephalus, it can cause microcephaly, it can cause hepatosplenomegaly. These are some key factors that you need to keep in mind. And also sensory neural deafness is seen with cytomegalovirus. These are some key points that you have to keep in mind. All right, now going into the second half. Second half is on immunology. We're going to talk about immunity, hypersensitivity reactions, and also something about the Rhesus disease in pregnancy. Now, coming to immunity, the most common one that you have to remember is your innate immunity and your adaptive immunity. Now, what is an innate immunity? Innate immunity is non-specific or immediate. This is present from birth. There is no memory and it is rapid. That means within minutes to hours. What are the physical barriers? Your skin, your mucosa, your cilia, and low pH. All these are examples of your innate immunity. Cells like your neutrophils, your macrophages, your natural killer cells, dendritic cells, all these are the various cells that are seen associated with innate immunity. Complement system, your cytokines or interferons, they are also seen with innate immunity. And your pattern recognition receptors, which is called as your PRR, like your toe-like receptors, all of them also are a part of innate immunity. Now, coming to adaptive immunity means specific immunity. It has a delayed immunity and it has a memory also. And this is going to develop over days. Here you have antigen specific and it also has an immunological memory. Now, for your adaptive immunity, there are two different terms you have to keep in mind. One is your humoral, that is your B cell immunity. Second one is your T cell, which is your cell-mediated immunity. Now, coming to your innate immunity. Innate, as I mentioned, it is non-specific. It is present from birth and it has no memory. So, key important point for your exam. Adaptive immunity has memory. It is faster. You have to keep this in as a difference between your innate immunity and your adaptive immunity. Now, coming to the various responses of your adaptive immunity, as we already saw, these are specific immunities, and this usually develops over days. Now, you have two arms in your adaptive immunity, which is your humoral or your B cell immunity and your cell mediated or your T cell immunity. Now, coming to your B cell immunity, in B cells, you have your plasma cells. Plasma cells produce antibodies, and they form your memory B cells. The primary B cell response is the production of IgM antibodies, and secondary is going to be your IgG antibody production. Now, coming to your cell-mediated immunity. In cell-mediated immunity, you have your T cells. Here you have your CD4 helper cells, which is going to recognize your MHC class 2, and you have your CD8 cells. Your CD4 are called as your helper cells and your CD8 are called as your cytotoxic T cells. Your CD8 is going to recognize your MHC1. So this is a key difference between your CD4 cells and your CD8 cells. Now, coming to your MHC and your HLA, you have your MHC1 and you have your MHC2. Your MHC1, we know it is associated with your CD8 cell and your major histocompatibility complex, that is your MHC. Your MHC2 is associated with CD4 cells. So these are potential areas in which your SBS can be targeted. Humoral cells, what are they produced? See, your cell-mediated, what are your CD8 cells? What are your CD4 cells associated with? This is some key area for your exam. Now, we saw the CD4 helper cell. CD4 is basically for your MHC2. Your T helper 1 cells are your intracellular macrophages. Helper 2 cells are your humoral or for allergy. Your CD8, that is your cytotoxic T cells, they recognize MHC1 and they kill the infected cells. Now, what are the memory B cells useful for? Your B cell is basically for your humoral immunity. Your B cell produces your plasma cells and your plasma cells are the one that produce your antibody response from the body. And again, we were seeing the differences between your major histocompatibility complex 1 and 2. One is for your CD8 cell, they are your nucleated cells, and 2 is for your antigen presenting cells, which are your CD4 cells. Now, coming to your antigen presenting cells, what are the examples here? You have your dendritic cells, you have your macrophages, and also you have your B cells. Your primary response is generally slow and it is from your IgM, and your secondary response is fast and it is strong, and this is your memory from your IgG. This is the difference between IgG and IgM. Now let's look into the important recalls of your innate and adaptive immunity. Innate immunity is immediate, there is no memory. Adaptive immunity, it is specific and it has memory. Your NK cell is a classical example of your innate cell, innate immunity. This is going to kill the virus and it also kills the tumor cells. Whereas your CD4 cells, if you see, you have your helper T cells. Your helper T cells are against your MHC2. Your CD8 cells are your cytotoxic T cells, and this is against your MHC1. MHC1 is for all nucleated cell and MHC2 is for the antigen presenting cells. Your B cells are going to produce your plasma cells, and from your plasma cells you're going to get your antibodies. Now, coming to primary response, it is from your IgM, and secondary response is from the IgG. These are some key points you need to remember about immunity. Next one is about the immunoglobulin and the complement system. When you take immunoglobulin, there are 5 different types: GAMED, GAMED. So G is IgG, which is the most abundant one. It is seen 75%, and this crosses the placenta and provides passive immunity. And the secondary response, opsonization, all this comes from your IgG. Now coming to IgA, IgA is present in the mucosal layer. It is present in secretions like saliva, breast milk, and this is a dimer. Coming to IgM, IgM is the largest in size. It is a pentamer. This is the first to be seen in primary response, and this cannot cross the placenta. This is best at complement activation and acute infection marker. Coming to IgE, IgE is associated with allergy and parasites, and this binds mast cell. This is seen in type 1 hypersensitivity. So this is an again key SBA point here. IgD is seen in B cell surface receptor. The role is unclear. When you look at the structure of immunoglobulin, it has 2 heavy and 2 light chain along with the binding, which is your Fab binding, and an effector, which is called as FC. Now, you have to remember that there are 5 immunoglobulin classes. You need to know the specific characters of each of these immunoglobulin, which is a potential SBA in your exam. Now coming to the complement system. If you look at the complement system, there are 3 activation pathways. We have the classical, which is your antibody driven pathway, which is your IgG or IgM. Now you have your alternate pathway, which is your pathogen surface derived pathway, and you have your lectin mannose binding pathway. All of them converge at one point, which is your C3 convertase. Your C3b is for opsonization. Your C3a and your C5a is they act as anaphylatoxins, and your C5b to 9 they have your membrane attack complex. These are the key things you need to keep in mind. Now, coming to neonatal immunity. What happens in neonatal immunity? The IgT is the one that crosses the placenta, and this provides passive immunity for the first 6 months. And this wanes as the maternal IgG declines. Now coming to IgA, IgA is present in the breast milk and colostrum, and this gives you mucosal protection, and IgM in the neonate, especially congenital infection, and this doesn't cross the mother. So when the baby is having IgM, remember we are dealing with congenital infection and there is no immunity there. Now, complement system, as we just saw, we have 3 different pathways of complement system: the classical, the alternate, and your lectin mannose binding pathway. The functions: C3b, opsonization; C3a, C5a, anaphylatoxin, so it is associated with inflammation, chemotaxis; and C5b to 9 is your membrane attack complex, that is your MAC complex, and this lyses the cells. Now, looking at the deficiencies, your C1 esterase inhibitor deficiency is the one that is seen with hereditary angioedema. Your terminal, that is C5 to 9 deficiency, is seen in Neisseria infections. And only IgG crossing placenta, this produces your neonatal passive immunity, and also your IgA that is present in breast milk. So, going with immunoglobulins and complement system, what do we just see in the recall? IgG is the most abundant one. It crosses the placenta. IgA is seen in the mucosal secretions and in breast milk. IgM is the first response. It is the largest in size. IgE is the one that is seen in allergies and parasites. So remember, mast cells, it is your IgE. And IgM is the best complement activator. Coming to the complement system, the classical pathway of your complement system is antibody triggered, and your C3b of your complement is associated with opsonization, and C3a and C5a is seen with anaphylotoxins. Your C5b to 9 is associated with your membrane attack complex, and C1 inhibitor deficiency is the one that is associated with hereditary angioedema. And these are the common ones that we expect or see in your exams. Coming to hypersensitivity reactions. Hypersensitivity reactions is another area that is seen in exams. We have four different types of hypersensitivity. We have type 1, type 2, type 3 and type 4. Type 1 is your immediate response. It is IgE mediated. It is anaphylactic. IgE is present on the mast cells. This causes degranulation and release of histamine. This occurs within minutes. Classical examples are anaphylaxis, urticarias, asthma, hay fever, etc. The treatment of choice is going to be adrenaline and antihistamines. Your type 2 is your cytotoxic, that is your antibody mediated. It can be either IgG or IgM. So what happens is the antibody binds to the cell surface antigen, and this can lead to phagocytosis or complement activation. The classical examples here are your hemolytic disease of newborn, your ABO transfusion reactions, and your Goodpasture syndrome, myasthenia gravis, everything come under this. Now coming to your type 3 hypersensitivity reaction, which is your immune complex mediated. You have your antigen antibody complex, which gets deposited in the tissues, and this leads to your complement activation or inflammation. Classical examples here are your SLE, your post-streptococcus glomerulonephritis, and your serum sickness, rheumatoid arthritis, all of this come here. Coming to type 4 hypersensitivity, this is your delayed reactions. This is T cell mediated, and remember there is no antibody here. The sensitized T cells stay in circulation, and after 48 to 72 hours, you see this kind of hypersensitivity reaction. Classical example for this is going to be a Mantoux test of your tuberculosis, your contact dermatitis, and your graft rejection. Your granulomatous diseases and your Stevens-Johnson syndrome are seen with your type 4 hypersensitivity. Now, what are the key things you need to remember in your exam? They can either give you an example and ask what type of hypersensitivity it is, or they can give you the classification or the definition of the hypersensitivity, and they can ask you for examples. Now, how are you going to remember this? One is your anaphylactic, two is your cytotoxic antibody mediated, three is your immune complex, and four is your delayed T cells. This is about your hypersensitivity reaction. Let's look into some important recalls here. You have your type 1, that is IgE, which causes immediate anaphylaxis. Your type 2 is your cytotoxic antibody, which is associated with your Rhesus and your ABO incompatibility. Type 3 is your immune complex that is seen in SLEs. Type 4 is your delayed T cell, which is seen in TB and contact dermatitis. How are you going to remember it? Anaphylactic cytotoxic immune complex delay, ACID, acid for 1, 2, 3, and 4 of hypersensitivity. Your Rhesus disease, commonly asked in exam, is your type 2 hypersensitivity. Your SLE, again very commonly asked in exam, is your type 3 hypersensitivity. Your Mantoux test is your type 4 hypersensitivity reactions. Now,
Hi,
of
ma'am.
all the,
Hi,
yes,
Priyadarshini, ma'am. Ma'am,
yeah,
your camera is off. Could you please turn on your
yeah.
camera?
Yes, I'll do that. Your type 1 hypersensitivity, you need to treat with adrenaline, and type 4 is the only one that is without any antibodies.
Uh, Supply, you're around Priya, so you're still in the OPD, Priya. Yes, Priya.
Yes, ma'am.
No problem, darling. If this is done, then probably I think Tazeen would be joining, and I think Sapna is there as well. So probably let them talk to the students. So if you have finished this PPT, then probably you can take care. Like Sapna would be
Yeah.
there till Tazeen joins. Okay.
I have done till hypersensitivity
No
reactions.
problem.
From
I'll ask
immunology
Tazeen
we
to
have.
take. No problem. I'll ask
All
Tazeen
right.
to take it from there. Thank you, Priya.
Thank you, ma'am.
Guys,
Thank you.
actually Tazeen was stuck in a surgery, so that's why Priya had to fill in. But Priya has got some work, so now Sapna is there till I think Tazeen would join in few minutes. Okay, thank you, guys. Thank you, Sapna.
Yeah, yeah. So I hope everybody is listening in and you've joined, because I think somebody was asking what are the topics we are going to cover. Please, always, whatever we are covering is very important, because these are like make or break modules. Okay, so all of these things that we have discussed in brief, these are all very, very, very important topics. Okay, so uh, I don't know, should I carry on with the session or how do I go about it?
No,
We'll wait for
probably
Tazeen.
because I think they have been asking few tips and tricks as well. So if you could do that, I think Tazeen is joining. So if you could just do the tips and tricks by then, Tazeen let her open the session and
Tips and tricks session is later, but okay.
few things, Sapna. Come on.
Right, right. Okay, so let me just talk about what kind of questions come from micro. Okay, so GBS, like Priya said, is very, very important. Okay, GBS is very important in clinical management part of RCOG part 1 and also in microbiology. So you should know what is the symptomatology, when do you actually test for the GBS in the mother, when do you not test. Okay, there are cases when they're going to give you questions like there's a 26-weeker patient and you've done a vaginal swab on her and it has come GBS positive. So do you give her prophylaxis? So no, you will not give her prophylaxis at the moment, but you will give her prophylaxis during labor. Similarly, they'll say if a patient has come and her urine culture has shown up GBS positive, so are you going to give her antibiotic prophylaxis now? Yes. So you're going to give her antibiotic prophylaxis now as well as during labor. So that particular flow chart is very, very important. So when to do the test and when not to do the test, okay? And on request, it is not usually offered, okay? So if a patient comes to you that my friend has got this problem and her baby was suffering and I'm very anxious, so please do a test for me. So NHS does not do tests on offer for GBS. Then about GBS, talking about the allergies. Okay, Tazeen has also joined in. I'll just finish the allergy bit, Tazeen, and then you take over, please. So about allergies also. So if the penicillin is the drug of choice. However, if they are allergic to penicillin, then you give her vancomycin. But if the allergy is just like, okay, I had an allergy last, I had a big reaction. Okay, what reaction was it? It was vomiting. So if a patient has an allergic reaction, which is like simple, like vomiting, nausea, that is not considered as an allergy. And if that is the level of allergy, then you will continue with the penicillin, which is drug of choice. Okay. I'll hand over to Tazeen. And if any queries or anything, definitely you're open. The chat box is open and you can always post your queries. So Tazeen, welcome and take over, please.
So much, Dr. Sapna. Thank you so much. And yes, I will
I'm
start.
filler of the filler. Okay, bye.
Thank you. Thank you.
Does it 7.9 onwards, I think.
Yes,
So
this
I
one
think
is 7.8.
the next slide.
Yes.
Yeah, this was covered.
Yeah,
The next
next.
slide you can start. Thank you.
All right. Okay. Hi, everyone. Thank you so much for joining and warm welcome. And let's continue the session from here onwards. And let's see that what we have to discuss. So immunology of pregnancy and Rhesus disease. All of us, we know that this one is very, very important as far as exam is concerned, as Rhesus autoimmune process, and how about the RH incompatibility that is frequently tested in the exam, and we should be aware about that. So basically, about the rhesus disease, once again, I'm emphasizing that this is important topic. So immune tolerance of fetus, basically it acts as semi-allograft, and the trophoblastic cells, as we discussed earlier as well, that trophoblastic cells, they express HLA-G, not classical HLA, and it evades natural killer cells and T cells. Okay, so then there is shift, which is the immune changes in pregnancy, that the shift is there to Th2 dominant immunity, less cell mediated rejection, and then these cells basically they suppress the anti-fetal response. Progesterone immunomodulation is always there, and that is also a part of pregnancy. And then basically what actually is tested in the exam is about the various hypersensitivity reactions, and what is the type of reaction, and what actually the mechanism is happening in those reactions. When we talk about rhesus incompatibility or rhesus disease of the newborn, that is basically type 2 hypersensitivity reaction. Okay, Rh negative mother is there, and when the baby, the fetus which is conceived, that is Rh positive, that is basically rhesus disease. And the sensitizing event is basically the maternal anti-D IgG which crosses the placenta. So that also, you know, that the antibody which crosses placenta, that is IgG. And basically the first pregnancy is usually unaffected, as sensitization events, they usually happen at the time of delivery as well. So subsequent Rh pregnancies, there can be hemolytic disease of the newborn. Okay, so that is something which you have to remember. So in the first pregnancy, basically what happens, that at the time of delivery, basically sensitization mostly, most common is the sensitizing event that can happen, although there can be other sensitizing events as well. If there is maternal trauma, if there is bleeding that is happening, abruption that happens. Okay, so these are the sensitizing events which can happen as well. So in the subsequent pregnancies, basically now the maternal antibodies, they have crossed placenta. Okay, fetal antibodies, they have crossed placenta, and the mother now is having antibodies, the mother is sensitized. Okay, so now what will happen next time? Now these antibodies, basically they are there, they are ready to attack on the fetal cells. So next time when it would be Rh negative mother and Rh positive baby, then this immune reaction will happen. Okay, and then this will lead to fetal hemolytic disease of the newborn as well. So the sensitizing events, as I told, this can be delivery, this can be miscarriage. In case of ectopic pregnancy, sensitizing event can happen. Antepartum hemorrhage, okay, external cephalic version, that is something which we have to take care. Okay, and then amniocentesis and abdominal trauma. Okay, anti-D prophylaxis should also be given. Okay, and routine anti-D prophylaxis is given at 28 weeks. We can give 2 doses at 28 weeks and 34 weeks, or a single dose can be given at 28 weeks to all Rh negative women in the subsequent pregnancies to prevent the hemolytic disease of the newborn. And then if there is any sensitizing event, then also anti-D would also be given. So immunology of pregnancy, when we are talking, so sensitizing events, as I have emphasized in the previous slide as well. So you should be able to understand that what are the sensitizing events. This is delivery, miscarriage, ectopic pregnancy, external cephalic version, abdominal trauma. And you should be knowing that anti-D prophylaxis, at what gestational age we are giving anti-D prophylaxis. This is exam tested area. Routinely we are giving after sensitizing event or within 72 hours. It is more effective when it is given within 72 hours. Klehor test basically is done when there is sensitizing event, and we expect that there can be large fetomaternal hemorrhage as well. So we have to calculate the dose of anti-D. Basically 125 ml is neutralized by one sorry. So actually we have to calculate the dose of NTD. So how actually we are calculating the dose of NTD? That is that 250 international units when 150 ml is basically neutralized by this. Okay, so when we are using the Klihor test, that is somehow we are trying to calculate the dose. The reason is basically that if the feto-maternal hemorrhage is larger, then what will happen that this will we may need extra dose of NTD, and that can help to calculate the dose of NTD. NTD mops up the fetal cells before maternal sensitization. So what is the purpose? Why we are so much concerned that we have to give NTD? Okay, so NTD basically the preparations which are available: 500 ml international units, 250 we can give, 1500 is a standard preparation which single dose is given usually after delivery. So what actually happens that when we are giving 125 ml of NTD, that will neutralize 4 ml of feto-maternal hemorrhage. Okay, so when we are quantifying the feto-maternal hemorrhage, we will come to know how much feto-maternal hemorrhage it is and how much exactly is the dose of NTD which we have to give. Okay, so then what will happen when hemolytic anemia is happening? What actually will happen to the baby is definitely, if hemolysis is happening in the baby, so then there might be fetal anemia. So what we can do the monitoring to assess that if this is hemolytic disease of the newborn, and if hemolytic anemia is happening, fetal anemia is happening, so we can do middle cerebral artery Doppler. Okay, and middle cerebral artery Doppler peak systolic velocity can be used to measure fetal anemia. This is also a question in parvovirus as well, and this is also a question in hemolytic disease of the newborn as well, that what we can do to monitor fetal anemia, that is middle cerebral artery peak systolic velocity. Okay, so the management now, the hemolysis is happening, so it is not mandatory that once the hemolysis will happen immediately there would be intrauterine fetal demise. Okay, first fetal anemia will happen, then the fetal organ failure will happen, cardiac failure happens in the fetus, then hydrops develops. Okay, so what can be the management that things can be reversed? That is basically intrauterine transfusion, or if the baby has achieved maturity, then we can go for delivery as well. Okay, ABO incompatibility can also be there, which can be mild hemolytic disease of the newborn. Okay, which can be severe hemolytic disease of the newborn. So all these things which we have to take care. Cell-free fetal DNA can determine RH status of the baby. Okay, so that why we are going to do for cell-free fetal DNA, that we want to know that whether the baby which is conceived by the mother, that is RH positive or that is RH negative. Okay, so that is something which you have to remember, is that if we are doing cell-free fetal DNA, we can determine the RH status of the baby, and we can understand that okay, we have to give NTD or not. Okay, so that can basically, we can avoid unnecessary NTD which can be avoided in this. Okay, so that is basically very very important. So now two important exam questions which are frequently asked, that NTD within 72 hours of any sensitizing event. When sensitizing event is happening, then NTD, we have the most beneficial effect is when we are giving within 72 hours of sensitizing event. What is meant by sensitizing event? That is delivery, that is miscarriage, that is ectopic pregnancy and antepartum hemorrhage, external cephalic version, amniocentesis, abdominal trauma. So now they won't be asking you straightforward that this sensitizing event has happened, so when you will give NTD. So they will give you a scenario that a patient has presented to you, this is her first pregnancy or this is her second pregnancy, she is at 28 weeks of gestation, so she had abdominal trauma and slight bleeding as well. So she is RH negative, and cell-free fetal DNA was carried out, and this is RH positive baby. So what you will do? in that scenario, now they are actually trying to assess you that whether you know that you have to give NTD, or you feel that I have given prophylaxis at 28 weeks. If this patient is at 30, 31, 32 weeks, I have given prophylaxis, now there is no need of NTD. Always remember that prophylaxis is given, but whenever there would be sensitizing event, you have to give NTD, and that NTD will protect the woman for 6 weeks. If after 6 weeks there is another sensitizing event somehow, you have given prophylaxis, but then you again have to give NTD, that is after sensitizing event, and prophylaxis is a different thing. Okay, so that is a major concept which you have to remember for your exam. Okay, so the fetus basically semi-allograft trophoblast is basically expressing HLA-G, which is non-classical. Pregnancy is basically T helper 2 dominant shift is there. Rhesus disease is basically type 2 hypersensitivity. Okay, Rh negative mother is basically when Rh incompatibility or Rhesus disease happens when mother is Rh negative and fetus conceived is Rh positive. First pregnancy is sensitization. Okay, NTD basically is given at 28 weeks. NTD within 72 hours of sensitizing event. Okay, Klihar test is basically done to understand how much is the amount of hemorrhage. Okay, we are quantifying the hemorrhage so that we can exactly quantify that what actually is the dosage of NTD which we have to give. Middle cerebral artery Doppler detects fetal anemia, and NTD IgG crosses placenta. So now we should be also knowing about the antibodies, which antibody crosses placenta, which is secreted in the secretions. Okay, which one is produced first in the body, which one is crossing placenta. All these are your exam questions which you have to remember. Okay, then there comes vaccination and immunization in pregnancy. Okay, about vaccination and immunization in pregnancy, basically what we have to remember is that there are various types of vaccines. Okay, so few are live attenuated vaccines, then there are basically inactive vaccines are there. Okay, then there are vaccines which we know that these are subunit vaccines are there. So basically there are various types of vaccines which are there. Okay, and this is your exam question that they can ask you which type of vaccine is that. Okay, so the live attenuated vaccines, these are MMR, measles, mumps, rubella, varicella. BCG is your exam question, which is frequently asked, that BCG is which type of vaccine? Yellow fever, oral polio vaccine, and nasal flu. All these are live attenuated vaccines. And what is meant by live attenuated vaccines? Basically, these vaccines are the vaccines which we have to avoid in pregnancy. Okay, they are contraindicated in pregnancy. So there is theoretical fetal risk. There is no evidence that fetal risk will happen, but theoretically it is thought that the fetal risk can happen. Then there are inactivated or killed vaccines. So it is a killed vaccine. So that is basically something which we have to remember is that this vaccine is basically we can give in pregnancy. So the inactivated vaccines are toxides, tetanus, diphtheria. Okay, subunit vaccines are conjugate vaccines, which are pertussis, human papilloma virus, hepatitis B. Among these, HPV is your exam question. Okay, among these, tetanus is your exam question. That tetanus is which type of vaccine? Inactivated. Beta HCG is which type of vaccine? That is live attenuated. HPV is a subunit vaccine. These are your exam tested recall questions which have been previously asked in the exam. Okay, so when we say that these are your exam tested questions, now always remember that basically the exam tested questions, if they ask that once they ask this about beta HCG, that this is your which type of vaccine it is, so next time definitely they can ask about measles, mumps, rubella. Next time, definitely they can ask about oral polio. Next time, definitely, if the question is revolving around this aspect, so next time, definitely they can change the direction of the question. So that's why we always tell you that one exam tested question, when which the recall question you say, that is one topic. Okay, that is giving you a clue that this topic is a high yield topic and this is tested in the exam. So next time, definitely they can ask you some different area from the same, and you should be ready. You should be ready to answer that area as well. Okay, so that is something which you should be knowing, and that is something which they can ask in the exam. Okay, so then there is messenger RNA COVID-19. Okay, so they ask you in the exam that what type of RNA is there in the COVID. Okay, so that is basically messenger RNA. Okay, then recommended in the pregnancy are basically pertussis whooping cough vaccine you can give at 16 to 32 weeks, which will protect the neonate. Influenza inactivated vaccine that can be given at any time. Okay, so then there is basically COVID-19. COVID vaccine was safe in pregnancy. Okay, there was a lot basically which was asked that whether it is safe or it is not safe, but it is a safe vaccine, which we should understand that this is safer. Then there are basically from the vaccination, then there is immunization and the types of immunity, that what are the various types of immunity and how to go about. Okay, so immunity types are basically, one is active immunity. Okay, the own immune response system is there, infection or vaccine. Okay, and it is long lasting. Okay, so basically whenever the infection will be there, okay, so the immune system is there, own immune system is there, the immune response would be there. Okay, so whether it can be this immune response can be due to the previous infection. If it was previous infection, then immunity has developed. Okay, or this is due to vaccine, why the BCG is given at birth to provide immunity. Okay, so then it can be the immune response which is due to vaccination. Okay, and that is long lasting. So live vaccines, they are strong and they need intact immune system. Okay, so live vaccines just like BCG, oral polio vaccine. Okay, we talk about measles, mumps and rubella. So they basically need a very strong immune system for intact immune system. Then there is basically passive immunity. Okay, so the name indicates that there are preformed antibodies which are there. Okay, and these preformed antibodies are basically there, and they will provide the temporary relief from that. Okay, so these antibodies basically they are maternal IgG to the fetus. Then immunoglobulin injections, as the immunoglobulin injections are also given. Then we say that few of the antibodies, they are secreted in the breast milk. Okay, antibodies are crossing placenta. Okay, so these are the things which we have to keep in mind, that these are basically the passive immune system. Okay, post exposure immunoglobulins are given. So if we want to recall the example of post exposure immunoglobulins, that is basically varicella zoster. Okay, immunoglobulins for varicella exposure. Hepatitis B IgG for neonates is there. Anti-D is there for Rhesus. HPV vaccine is there, which prevents cervical cancer. Okay, Gardasil 6, 11, 16 and 18, ideally given before sexual debut, not in pregnancy. Rubella is basically non-immune. Okay, we can vaccinate in the postpartum period, as pregnancy is basically ideally pregnancy should be avoided for 1 month. Okay, so for if we are giving the vaccination rubella, since how long we have to avoid pregnancy? 1 month, and that is also exam tested area. Okay, that is also exam question which is asked in the exam. So live vaccines, we are avoiding live vaccines in pregnancy, and the examples of live vaccines are basically beta HCG, oral polio vaccine is there, influenza vaccine is there. Okay, so these are the things which we have to remember. Pertussis is given at 16 to 32 weeks. Okay, COVID vaccine is safe in pregnancy. Okay, that is something which we have to remember. And then there is passive preformed antibodies are there in the passive immunity. Okay, then there is basically HPV vaccine we are giving before sexual debut. Okay, so basically HPV vaccine we are giving before the sexual activity starts in the woman. Okay, so when we talk about live vaccines, basically live vaccines are measles, mumps, rubella, varicella, beta HCG, yellow fever is there. Okay, so that is something which we have to remember, that this is something which is important. Influenza is inactivated. Any trimester we can give influenza vaccine. Okay, active immunity is basically when the on response is there. Okay, on response means active immunity is there. So which we have to remember, varicella zoster immunoglobulins are given for after exposure immunity, which is varicella, that post exposure immunoglobulins are given. And rubella vaccine is basically given in the postpartum period, and this rubella vaccine is basically not given in the pregnancy. Okay, so then there are basically questions which we have to remember, that these questions are from the exam tested areas. So which is a feature of the adaptive immune response? Okay, adaptive means it has been adapted and it was not there, it was not innate, it is adapted. Okay, so what is the feature of adaptive immune response? That immediate response is there, immunological memory is there, natural killer cells are there, complement activation is there, or physical barriers are there. Okay, so what is the response which we have to remember, that this is something which should be remembered. So that is basically as it has adopted. Okay, so immunological memory is there. Okay, so adaptive immunity is basically antigen specific and it has memory. The basis of vaccination. Okay, why we are giving the vaccination? That the memory is there. Okay, that should be kept in mind. Okay, so innate immunity is basically immediate, non-specific, and it lacks memory. Natural killer cells, complement, barriers, phagocytes. Okay, that is basically innate. Adaptive is which one is having memory, and this is your exam tested question as well. Okay, then there is CD8 cytotoxic T cells recognize antigen presented on. So is it on MHC class 1, major histocompatibility class 1, major histocompatibility class 2, complement C3b, toll-like receptors, or immunoglobulin FC. So basically what actually we have to remember, that CD8 cytotoxic T cells basically they recognize antigen which is presented on class 1. Okay, major histocompatibility class 1, that it is basically presented on class 1. Okay, so then there is basically we have to remember that where the CD4 is expressed. Okay, CD4 is basically CD4 helper T cells, that is major histocompatibility class 2. Okay, 4 multiplied by 2 is equal to 8 on antigen presenting cells. Okay, so basically CD8 is class 1 and CD4 is class 2. 2 4 multiplied by 2. Okay, so this is how you can remember. Which immunoglobulin is the only class that crosses placenta? And I feel from the past few exams that no exam is without this question. This is such a simple, easy question. Okay, no, nothing to be worried much about this question, but still this question is a frequently tested question as well. Okay, so which immunoglobulin is the only class that crosses placenta, whether it is IgA, whether it is IgM, IgG, IgE, or IgD? And we all know that this is basically IgG. IgG is the only immunoglobulin that crosses placenta, providing passive immunity to the neonate for the first 6 months. IgM pentamer is too large. Raised IgM in a neonate suggests a congenital infection which did not come from the mother. Which immunoglobulin is first produced in the primary immune response? Okay, like which one is the first one which is produced in the body, which is produced as a first primary immune response? Whether it is IgG, whether it is IgA, whether it is IgM, whether it is IgE, or whether it is IgD. Okay, so which one is basically produced, and the one which is first produced in a primary immune response, that is IgM. The one which is crossing placenta, that is IgG. Okay, these are the things which we have to remember. So IgM, a pentamer, is the first antibody in the primary response and the best complement activator. IgG dominates the secondary memory response. IgA is found in mucosal secretions and breast milk. IgE mediates allergy. Okay, IgE is associated with allergy. IgA is associated with mucosal secretions. Okay, IgG dominates the secondary response. IgM is the first antibody which is produced in the primary response, which we have to take care. So that is something which we have to remember for this. Anaphylaxis is a which type of hypersensitivity reaction? So these types of hypersensitivity reaction, again very important exam tested area, again a must question which is asked from immunology and microbiology. Okay, so which type of anaphylaxis is, whether it is type 1? So how we have to remember from type 1? This is IgE mediated. Okay, how we have to remember type 2? Cytotoxic. How we have to remember a type 3, which is immune complex mediated. Okay, how we have to remember type 4, that is a delayed immune hypersensitivity reaction. How I have to remember type 5, which is stimulatory. Okay, so anaphylaxis is basically type 1, that is immediate hypersensitivity reaction. Okay, then there is basically it is IgE mediated. Okay, and anaphylaxis, what is meant by anaphylaxis? These anaphylaxis, basically these are the things which is urticaria is there, asthma is there. Okay, so this is how basically the anaphylactic reactions are happening. Okay, cytotoxic response is class 2. Class 3 is basically immune complex mediated. Okay, all the immune diseases, they are falling in this category. Type 4 is a delayed response. Okay, that also you have to remember that type 4 is a delayed response. And then type 5, that is basically a stimulatory response, which you have to remember. Rhesus hemolytic disease of the newborn is a which type of hypersensitivity reaction? Whether it is type 1, type 2, type 3, type 4, type 5. Okay, so Rhesus hemolytic disease of the newborn, that is a type 2 cytotoxic reaction. Okay, so that is the type 2 cytotoxic reaction which we have to remember. So fetal anemia is there, ABO transfusion reaction is there, autoimmune hemolytic anemia, that is there. So they are all basically type 2 immune responses which are basically happening for this. Okay, and then there is basically question number 7, that a positive Montauk's test. So a positive Montauk's test is basically a tuberculin test at 72 hours is an example of. Okay, so they are asking basically that the positive Montauk's test, which type of reaction or which type of hypersensitivity reaction it is. Okay, so this is basically type 1 hypersensitivity reaction, or type 2, type 3, type 4, or this is IgE mediated reaction. So basically a positive Montauk's, which is a tuberculin skin test, that is basically type 4 hypersensitivity reaction. Okay, the tuberculin reaction is type 4, delayed T cell mediated, peaks at 48 to 72 hours, no antibody involved. Other type 4 examples are contact dermatitis, okay, that can be graft rejection, that can be granulomatous disease. So all these are basically type 4 reactions which we have to remember. And then there is a question which is basically question number 8, that routine antenatal anti-D prophylaxis is given to the RH woman at what gestational age? Okay, so we learned it many times that at what gestational age basically we are giving this, whether we are going to give it at 12 weeks, whether it is 20 weeks, 28 weeks, only after delivery, every 4 weeks from the booking. Okay, so basically prophylaxis is given at 28 weeks. Okay, so we are giving the prophylaxis at 28 weeks. Routine antenatal anti-D prophylaxis is given at 28 weeks to all RH negative women, plus within 72 hours of the sensitizing event, the Klehor test quantifies fetal-maternal hemorrhage to determine the dose. Okay, so then there is anti-D immunoglobulins should be given after sensitizing event within how much time period? Okay, so within how much time period the anti-D immunoglobulins basically they are given? So the whether we are going to give it within 6 hours, whether we are going to give it within you know we are going to give it within 24 hours, when whether it is 72 hours, whether it is 1 week, 2 weeks. So one thing which we have to remember is that this is basically 72 hours. NTD should be given within 72 hours of a sensitizing event. Okay, delivery, miscarriage, ectopic, antepartum hemorrhage, ECV, okay, amniocentesis, abdominal trauma. It mops up fetal Rh positive cells before the maternal immune system is sensitized. And when we do the quantification, basically we are doing the quantification, we want to know that what actually would be the dose of NTD. Ideally, it is considered that 125 ml, 125 international units of NTD, it will neutralize fetal-maternal hemorrhage of 4 ml. If it is 8 ml, then the required dose would be higher. Okay, then 125 multiplied by 2, it would be 250 international units. Okay, so 125 international units will neutralize 4 ml. So if they give you some fetal-maternal hemorrhage, then they give you various dosage. By knowing about the fetal-maternal hemorrhage, that 4 ml will be neutralized by 125 international units, you have to calculate the dose of NTD, and then you have to decide about the exact dose of NTD. So which vaccine is contraindicated in pregnancy? As we discussed, that what are the vaccines which are contraindicated in pregnancy, whether it is inactivated influenza vaccine, whether it is pertussis, which we are giving at 16 to 32 weeks, MMR, which are live attenuated vaccines. Okay, then it is basically tetanus toxoid. So which vaccine we actually have to give during pregnancy? So that is basically something which we have to remember, that this is basically contraindicated is are the live attenuated vaccines. Okay, so live attenuated vaccines are basically the vaccines which are contraindicated. So MMR is a live attenuated vaccine, so that is contraindicated in pregnancy. Okay, then other live vaccines are basically beta HCG, yellow fever, pertussis, inactivated flu, COVID-19. They are recommended in pregnancy. So about the microbiology and about the immunology, the high yield recap is basically gram positive bacteria. They are having thick peptidoglycan, and that is basically purple. Okay, then gram negative, they are having lipopolysaccharide membrane, and that is pink. Okay, Staph aureus, staph is basically clusters, and strep is basically in the chains, and staph aureus is coagulase positive. Okay, staph aureus are coagulase positive. GBS is basically the Streptococcus agalactici. Okay, they are the agalactici species which are there. Okay, so then there is endotoxins. Endotoxins are basically lipopolysaccharide, gram negative, and they are heat stable. Okay, so are heat stable, which we have to remember. Then exotoxins are there. Okay, so basically, just 1 minute. They are exotoxins. They are secreted and they are heat labile. Okay, then staph is basically chlamydia is obligate intracellular. Okay, chlamydia is obligate intracellular, and Sanusha, my screen is visible. Sanusha, my screen is visible.
No, yes, ma'am.
Okay, so then we were talking about chlamydia. Okay, chlamydia is basically obligate intracellular. Okay, chlamydia is obligate intracellular, which they are asking in the same way, which organism is obligate intracellular. Okay, so that can be asked. Then chlamydia is basically the commonest bacterial sexually shared infection, sexually transmitted infection. Gonorrhea is gram negative diplococci. Okay, so that is gram negative diplococci, and the gonorrhea treatment is basically that is something which uh, we have to remember, that that is ceftriaxone. Okay, syphilis is basically treponema, and penicillin is the treatment. Bacterial vaginosis, clue cells are there, pH is more than 4.5. Okay, trichomonas, strawberry cervix is something which is there in trichomonas, which is basically mentioned. Okay, so then there is basically bacterial vaginosis, trichomonas treatment is metronidazole, which we have to give. Candida is basically cottage cheese or curdy white discharge. pH is normal. Satellite lesions are there. Okay, fissuring can also be there. Fitzhug's is basically, Curtis is basically perihepatitis. Okay, HPV 6 and 11 are associated with warts, 16 and 18 are associated with cancer. Cytomegalovirus is the commonest congenital infection. So, if they ask you which one is the commonest congenital infection, that is cytomegalovirus, which we have to remember. Okay, then rubella is basically cataract, patent ductus arteriosus is there, deafness is there. Okay, parvovirus causes fetal anemia. And now someone has asked in the study group that how we monitor through peak systolic velocity. Basically middle cerebral artery is a Doppler, and we measure the peak systolic velocity in that. Okay, in the peak systolic velocity, we are, if it is more than 1.5 medians of mode, okay, then we say that this is fetal anemia, and we refer that patient to the fetal medicine unit. So if they say that you have done middle cerebral artery Doppler and PSV, peak systolic velocity, is more than 1.5, what would be your next step? In the exam question, your next step is referral to the fetal medicine unit. And there in the fetal medicine unit, basically they will do again a detailed anomaly scan and reassessment of the patient, and then in utero transfusion would be provided to the patient. Varicella, if it is less than 20 weeks, congenital varicella zoster syndrome can happen. Toxoplasmosis is associated with hydrocephalus and chorioretinitis. Toxo is very toxic, so it causes hydrocephalus, chorioretinitis. Okay, toxo from cat feces and raw meat. Toxo is basically, the treatment is pyramycin. Listeria is from unpasteurized dairy. Listeria treatment is amoxicillin. GBS is commonest early neonatal sepsis. GBS prophylaxis is basically intrapartum penicillin. Okay, if it is asymptomatic bacteria, still it needs treatment. Okay, we cannot leave asymptomatic bacteria as it can lead to pyelonephritis. Beta lactam are basically cell wall synthesis. Amino glycosides are basically 30. Trimethoprim is basically folate antagonist. Okay, just give me 1 minute. This is basically not responding. Zoom is not responding. Let me. Am I audible? This slide is so infectious that on this slide, Zoom starts responding, stops responding. Whenever I am trying to explain this slide, Zoom stops responding. Such infectious slide. So we were at the aminoglycosides. Aminoglycosides are basically, they are affecting the 30S subunits, macrolides 50S subunit, trimethoprim folate antagonists. Tetracyclines, basically they are contraindicated as they affect tooth, teeth and bone. Okay, then fluoroquinolones, they affect cartilage, that's why they are contraindicated. Trimethoprim is should be avoided in the first trimester. Okay, MRSA, they are basically associated that they alter the PBP. Calvolonate, basically beta lactamase inhibitors. Okay, innate immunity is immediate, no memory is there. Adaptive immunity is specific, and as it has adapted, so that's why some memory is there. CD8 is expressed on major histocompatibility class 1, on major histocompatibility class 2. Natural killer cells are the innate which crosses placenta. IgA is basically in the secretions. IgM is the first pentamer, okay, which is there. So CD8 is basically expressed on major histocompatibility class 1. CD4 is class 2, major histocompatibility class 2. Natural killer cells are the innate immunity. IgG is the most abundant antibody which crosses placenta. Okay, and then IgA is present in the secretions. Okay, IgM is the first pentamer which cannot cross placenta. IgE is associated with allergy. Neonatal IgM is basically present in congenital infections. Classical complement is antibody mediated. C3b is associated with opsonization. C5b to 9, they form the membrane attack complex, and that is again your exam question. Okay, that is also your exam question which is associated. So membrane attack complex is formed by C5b to C9. Okay, so then the hypersensitivity reactions, they are basically IgE mediated. Then class 2 are cytotoxic, class 3 are immune complex mediated, 4 are delayed, and then 5 class is there which is stimulation based. Type 1 are anaphylactic reactions. Okay, so these type 1 are basically which is associated with anaphylaxis. Type 2 are rhesus. Okay, type 3 are immune complex mediated. Type 4 are basically the reactions which are tuberculosis, Mantoux test. RH disease is basically type 2. NTD is 28 weeks within 72 hours event, and live vaccine which is contraindicated in pregnancy, that can be beta HCG, oral polio vaccine, live influenza vaccine can be there, MMR, measles, mumps, rubella. So these all are basically live vaccines which are there. Okay, so these all are basically the things which you have to remember. So this slide actually it has troubled us a lot, as there was a lot of Zoom not responding at this slide, and this is basically 60 questions are there on one slide. All are your exam tested areas, all are your exam questions which you have to take care. So be very careful, revise the things. Immunology, microbiology, that is volatile, you may forget at times, but definitely 8 to 10% weightage is there from all the 200 questions for your exam. So you have to be very careful that the questions which you know that this would be there in the exam, you cannot miss those questions in your exam. Okay, so with this, thank you so much for joining the session. That's all about immunology, and that's all about microbiology, and we will see you again for the next sessions. Thank you so much. Keep revising, stay motivated, keep up your dedication. Just few days till exam, and then you are done with your step 1, and you will be start preparing for the step 2, which is MRCOG part 2. Thank you so much once again, and have a great day.